grandfather is in his early 90s. He lives in central Nigeria in a village where he gets a lot of community support and assistance. He's still very active and participates in community activities as well as looks after some of his great grandchildren. For many Americans, aging like my grandfather is impossible for reasons related to funding, disabilities, diseases, and lack of family support. For optimal aging to be possible, it is important that long-term care options are tailored to a person's personal identity, and part of this is the ability for those people to age in place. Through the life continuum, finance affects access. This is especially crippling in old age. To mitigate this, a compulsory nationally ran long-term care insurance that integrates Social Security and Medicaid and provides carrots for behaviors and actions that promote health and wellness for every American should be established. This should have the goal of reducing financial, emotional, and social difficulties associated with aging and caregiving. On a community, organizational, and individual level, resources should be targeted at upstream measures of improving wellness earlier in life. This is to reduce disabilities and diseases associated with aging. This inherently reduces caregiving burden for the elderly and reduces the cost of care by compressing morbidity. Encouraging autonomy in children, but embedding a feeling of community and the ultimate need for one another is one way that we can achieve this goal. My question is, how would you plan for the aging of a child who is born at this moment? How would that be different from the plans that were made for children that were born when Medicaid was created in 1965?
Hello everyone, my name is Mitha Patel and today I'm going to be talking about the end-of-life care. More specifically, I will be discussing what end-of-life care is, what palliative care is and the benefits, and future steps you should take for yourself and your loved ones. We all know that death is inevitable, but when a loved one is affected by a terminal illness, it's not always easy to know how to react. In the final stages of an illness, it becomes clear that even the best care may not save our loved ones. So instead of focusing on curative measures, we shift the priority to making the patient comfortable. End-of-life care hopes to make death slightly more comfortable by providing the best quality of life until the end. This care helps patients with advanced incurable illnesses live in peace by managing their pain and symptoms. This can last weeks, months, or several years depending on the illness. The last stages of life are very challenging, so end-of-life caregivers, such as home health agents, nursing home personnel, hospice providers, and palliative care physicians, provide psychological, practical, spiritual, and grief support. Rather than dying in a hospital where you are constantly doing tests and procedures that will cost a fortune, we now have the option to receive care at home or a facility. Palliative care is a type of end-of-life care. Unlike medical care where you are treated as a patient, palliative care recognizes you as a person. This care is mostly for patients whose disease is unresponsive to treatment. However, it can also be used for anyone with a long-term disease that will in time probably cause their death. Palliative care improves the patient's quality of life by facing the problem associated with the disease through prevention and relief of suffering through early identification and assessment. They use interdisciplinary teams to provide comfort to their patients and offer counseling and support to families of the patient's treatment options and goals. Unlike hospice care, palliative care allows you to receive medical treatment and comfort care at the same time. Care can also begin any time during the disease. Studies have shown that early interventions of palliative care reduce direct costs, prevent depression, and help patients live longer. Palliative care shows positive effects on life, mood, and survival. Our society offers us a chance to die peacefully. They offer more patient-centered programs and give patients more autonomy on what services they want. What if something were to happen to you right now? Do you or a loved one know how you want your end-of-life care? No one knows when their time comes, so it's a good idea to spend time to plan out end-of-life decisions. While it may be uncomfortable and difficult, you have noticed that there are many options to choose from. Physicians urge individuals to talk with their families and healthcare providers about their care decisions. Figure out their goals of care, where they want to spend their last moments, and what treatments they want to receive. After making the decision, it is important to write it down. If an individual were unable to speak, physicians would know what to do. You have the right to die how you want, so it's important to have advanced care planning. Based on this video, my critical thinking question is, what are some ethical dilemmas that end-of-life care have faced?
Shifting demographics in the United States has created an urgency to find solutions to care for the aging population in a caring, respectful, and financially sound manner. Someone turning age 65 today has almost a 70% chance of needing some type of long-term care services and support. There's a misconception that Medicare will fund long-term care, and to be eligible for Medicaid, you must essentially be poor or have a disability. One solution to ensure older adults are covered for any type of long-term care services and support is long-term care insurance. Long-term care insurance is designed to cover long-term care services and support. Based on policyholder benefit selection, coverage can include home health, adult day services, hospice care, assisted living, skilled nursing care, occupational therapy, and many more. In 2012, the average cost was $2,000 per year, the benefit period was 3 years, and the daily amount was $150. It is recommended to get insurance between the ages of 50 and 60 years old. Many may not be eligible once an event happens. Long-term care insurance can be used in conjunction with personal or retirement savings. By planning ahead and being financially stable, an individual can maintain autonomy by having a greater choice in their own care. The Long-Term Care Partnership Program links special partnership qualified long-term policies by private insurance companies with Medicaid. This gives an individual a safety net if they need long-term care beyond the policy maximum. With this partnership, an elderly person receiving a private insurance care benefit can also apply to Medicaid. The program includes an inflation protection, a higher amount of benefits, and asset disregard. Asset disregard allows you to keep assets such as a savings account above the usual $2,000 Medicaid limit. The long-term care partnership can additionally help with caregiver support and be used toward home and community-based services, which promotes aging in place. Long-term care insurance can help an individual, but it can also relieve family member burden. Caring for an aging loved one can cause strain on a family member's finances and also affect their employment. Many family caregivers incur direct out-of-pocket costs by spending their own money on services that could be covered by insurance benefits. This may cause a family member to not save for their own future, thus creating a cycle of dependency. Family caregivers may have to change job responsibilities, rearrange work schedules, or leave the workforce altogether. In 2006, employers estimated a loss of $33 billion a year due to costs linked to employees who are full-time caregivers. Long-term care insurance can help by paying for more care and services. An aging person doesn't have to feel like a burden on the family giving them care. Long-term care insurance is a piece of the puzzle that represents the solution for financing long-term care. For that matter, long-term care doesn't have to be synonymous with institutionalized care. It is healthier to age in place than in a nursing home or hospital. As of 2014, only 8.1 million Americans have long-term care insurance. My question to you, should long-term care insurance be required like healthcare insurance is under the Affordable Care Act?
Hi, my name is Krista Caricado, and for for my Power of Three, I will be focusing on how we should improve support for family caregivers and the overall concept of aging in place. Most elders want to remain independent as they age, but there are several social and environmental barriers that we will need to overcome in order to improve this option for long-term care. According to the U.S. Census report, in 2010, there were 40.3 million people aged 65 and above, which comprised 13% of the overall population. And by 2050, the projected population of this group will comprise 20.9% of the population. This is a major increase and will continue to grow at a rapid pace. The increase of our aging population will have a significant impact on our economy due to more healthcare costs, specifically individuals with dementia and Alzheimer's. As a society, we need to prepare for the potential social and economic shift due to the increase of our aging population in order to overcome many barriers and financial challenges that we will be faced with. In today's society, we have many elderly individuals that want to stay at home and not be subjected to an institutionalized facility. As we look at the concept of aging in place, there are many barriers to include housing, transportation, and social support. We spend more money on acute care rather than preventative care options. Our communities need to focus on other contributing determinants and not just within the medical aspect. We need to develop stronger long-term care programs that will help support aging in place with families. Family support is a major influence on an elder's lifestyle, and it's critical that we evaluate more social support options for family caregivers in order to improve the quality of life for these individuals. According to AARP in 2013, about 40 million family caregivers in the U.S. provided an estimated 37 billion hours of care to an adult with limitations in daily activities, and the estimated economic value of their unpaid contributions was approximately $470 billion. That is a significant amount that has saved our economy in regards to long-term care, based solely on family caregivers. Tax breaks are not enough to support these family caregivers, and this issue needs to be addressed. Families that reside in rural areas have limited resources, such as access to jobs, health care, and even healthy food markets to provide for their loved ones. These limitations have an impact on a family's way of life, and these family caregivers should have more value placed on them in order to help relieve the burden of stress, financial hardship, and other barriers as a family caregiver. The reason I chose this topic is because my family is currently facing these challenges to provide for my grandmother, who is suffering from dementia after having a stroke earlier this year. My grandmother was independent and worked full-time at 80 years old until one stroke changed her whole lifestyle. My mother quit her job to be my grandmother's caregiver, but is faced with a financial hardship. In the past, our society has not focused on the concept of aging in place, but our communities are continuing to change and improve the overall social support of this concept. So my question to you is, how can we place a value on our family caregivers in order to support their loved ones without a financial hardship?
Hello, my name is Chloe Sanders, and I would like to share my Power of Three video with you all today. This presentation will focus on long-term care services culture change. Thank you and enjoy. The concept of nursing home facilities has changed considerably in recent years. The history of nursing facilities began in the U.S. in the 1800s within institutions called almshouses or poorhouses. These facilities were first created as a way of deterring the poor from depleting public funding. Between the 1820s and the late 19th century, almshouses sprouted up all over the United States. As the facilities grew, over time the population in the almshouses changed, and by 1880 was mostly comprised of an elderly population. The culture surrounding these institutions was one of dismissal. The almshouse was created out of a need to remove certain members from society, and as such, almshouses were terribly lonely places for the elderly to age. This dismissive attitude associated with aging population would persist in the U.S. in this way until around 1980. The quality of care aging residents received in the institutional setting has dramatically increased in the last 30 years. Long-term care institutions, such as Lutheran Homes of South Carolina, are buying into what is now referred to as the culture change movement. This movement involves viewing facilities as person-centered medical homes as opposed to healthcare institutions. This patient-centered model is based on an effort to engage in the aging journey with the elderly resident. This goal may be accomplished in any way that allows prolonged autonomy for the patient. For example, environmental modifications that allow the resident to move freely at their own pace. This also includes allowing animals into the facility for companionship or providing exercise courses for the purposes of stress management or self-esteem building. Unique to this culture change movement is the collaborative effort of elderly caregivers to engage in interdisciplinary team care. This collaborative effort involves inviting caregivers of all levels to join the discussion of patient care. This practice is clearly established in facilities such as Palmetto Senior Care and can be accomplished through the Program of All-Inclusive Care of the Elderly, also known as PACE. This model addresses the poorly integrated funding associated with long-term care services, as well as the importance of primary care. Facilities that implement this model enjoy strikingly low hospitalization rates, financial flexibility, and improved care quality for their residents. This, too, is a model of cultural change that recognizes the need for patient-centered care. It also addresses the social dynamics of aging in a way that is of the most benefit to the aging individual. The culture surrounding long-term care has changed significantly since the almshouse, but there is still a long way to go to ensure quality patient-centered aging services are available to every person who needs them. What do you feel is the biggest barrier to healthy, successful aging, and what can be done to overcome this barrier?
somebody's lack of love. Or you can start speaking up. Nothing's gonna hurt you the way the words do when they settle near your skin. Kept on the inside and no sunlight. Sometimes